All right, so let's hop right into ketogenic diet therapies for epilepsy. What is the ketogenic diet? In short, it is a high-fat diet that is also low in carbohydrate with adequate amounts of protein. And you can see here in this graphic that we've put the ketogenic diet at a 4-to-1 ratio, which I will explain later what that means, against a standard American diet. And you can see the differences in percentages of fat and protein and carbohydrate for all of these things. So when you follow a ketogenic diet or one that's high in fat, then your body will go into a state of ketosis. Next slide. So what that means when you're in a state of ketosis is that you are burning fat for energy instead of carbohydrate and sugar for energy. So we define ketosis that you can measure the levels of ketosis in your body by blood and by urine. So if the blood levels of ketosis are above a 0.5 millimole per liter range, then you are considered to be burning fat for energy and in ketosis. And to kind of give you a little bit of perspective on what this means, our children that are on a ketogenic diet for seizure management are really kind of in that 3, 4, 5 kind of millimole per liter range. Somebody who might be in a diabetic ketoacidosis, so kind of a crisis mode with diabetes, they might be in like 9, 10, 11, 12, sometimes even higher millimoles per liter range. So we're kind of like middle of the road somewhere in there for therapy for ketogenic diet for seizures. So we can use the ketogenic diet and being in ketosis just for general health purposes, either in treating chronic illnesses, which I think epilepsy and seizure management would kind of be in that category, but also for a lot of different reasons. You know, there are a lot of literature that's coming out these days on people using a ketogenic diet for diabetes and for Parkinson's and Alzheimer's, and you know, a lot of different things, including for optimizing mental and physical performance, and even some things that we're seeing that are coming out on sleep these days too. So a lot of different reasons why you might use a ketogenic diet. And we know that there are a lot of benefits in going into a mild state of ketosis, but for a mechanism of action for seizure control is not really entirely clear yet. There are many theories on how this is, you know, it has been documented, but there's not really just one idea of how it works to then be helpful for seizure control. The diet seems to enhance the ability of the mitochondria to deliver energy and reduce inflammation and stress during this process of burning fat for energy. So what's the difference between what we find maybe on the internet and what a ketogenic diet might look like to some people versus what we're doing here at Lurie Children's and using ketogenic diet for seizure management? I think it kind of comes down to the percentages of fat and protein and carbohydrate, and of those, that pie graph that I was showing you before. We can use different percentages of all of those macronutrients that might get us to kind of a different level of ketosis and what we might use it for. But the purpose of its use is also very important. So we need a therapeutic level of ketosis for our patients with epilepsy, but you might not need that deep level of ketosis for something like, you know, if you're using it for blood sugar control or something like that. So there are a lot of different ways to get about doing a ketogenic diet, and I think even the differences in definition of ketosis and what keto means to you actually, you know, keto to me means a high fat diet, where you're burning fat for energy. But to somebody else, keto might mean a low carb diet so that you're not eating a lot of carbohydrates, which would be your bread, cereal, rice, pasta, kind of that group of foods. So I think the definition also is different depending on who you are talking to. So there are a lot of benefits for a ketogenic diet in terms of epilepsy and seizures. Usually we use the ketogenic diet for patients who have failed traditional anti-seizure medications. Probably one or two medications would be the best candidate for diet therapy. And also maybe somebody who might not be a good candidate for epilepsy surgery. That might be a good candidate for a diet or alternate to medications. There's no age restrictions when we use ketogenic diet for our patients. We have patients that are a few weeks old, all the way to teenagers and adults. Of course, we're not treating a lot of adults here at Lurie Children's with keto. We are able to transition them over to the Northwestern system. They also have a diet team over there for their neurology team. But we try and do a few months trial of the diet therapy to see if it's going to be helpful for seizure control. And we usually like to say a couple of months, maybe up to 3 months of a trial for the diet. And you would probably be on the diet for a couple of years if we know that it's helpful, maybe 2 or 3 years. During that time, we would try and wean medications that maybe have not been helpful or maybe are providing some kind of side effects that we can, just take off of our plate so that we can just focus on things that are working and helpful. But a lot of our patients will remain on the ketogenic diet for years after that because they know it's been helpful for them and they're happy being on it. So we would just let them continue to be on it as we kind of monitor all of their labs and their neurology status and their weight and everything during that time. So I like this graphic from the Charlie Foundation, which is one of the best web sites that I know of that can be really helpful for not only professionals, but for patients and caregivers to learn more about the ketogenic diet. So it kind of starts off here on the left side with a newly diagnosed epilepsy patient. So you are newly diagnosed or you have a loved one that is newly diagnosed, and you have about a 47% chance of becoming seizure-free with your first medication. Unfortunately, there is a 53% chance that you would still have uncontrolled seizures. So you would go to a second medication, which you can see there. And unfortunately, the more medications that you try, if you continue to be in that uncontrolled seizure kind of bucket, then the worse or the harder it is to become seizure-free. You can see that those percentages are quite small the further or the more medications that you try. So really after the first or second medication, if patients are still intractable, then we would probably offer them a ketogenic diet at this point. So you can see at the bottom there where it says 10 to 25% of people who try a ketogenic diet therapy will become seizure-free. So it doesn't matter where you fall, if it's the first medication or if it's the third or fourth or fifth, that you would still get that kind of percentage as a possibility for seizure freedom. So how effective is the ketogenic diet? Since the 1920s, studies have consistently shown that children with difficult to control seizures of all different types of seizures are helped by the diet. So roughly, I like to say that it works 2/3 of the time to reduce at least half of the amount of seizures. that your patient is having. So at Lurie Children's, we looked at our specific numbers and our rates of efficacy and found that 86% of the time that we try a ketogenic diet therapy, it is helpful for the patient. So let me talk to you a little bit about our program here. Currently, we have a caseload of about 350 patients on a ketogenic diet therapy. So I've divided these into two different sections. There is KD, or classic ketogenic diet. We have about 310 patients in that category. And then the modified Atkins diet, or the MAD, about 40 patients in that section. So added together, about 350 for the whole program. And I will talk to you a little bit about what these two diets actually mean. That makes us one of the biggest keto centers in North America because of our caseload. So we do have a keto team here of a couple of nurse practitioners that do our keto clinic outpatient with us. And there's a picture there of myself and my registered dietitian coworker friend, Wes. And we follow all of our patients here, and we are soon to add 2 more registered dietitians that we were approved for. So we will have a team of 4 dietitians that follow all of our patients, which definitely makes us the biggest keto run center in North America and possibly the world. I don't know anybody that has 4 registered dietitians that is following their patients. So we're very happy, very proud of this accomplishment here. We do believe that diet therapy is a choice in your epilepsy treatment. So just to make a note of that, that we really make sure that we vet all of our patients and their caregivers to make sure that they know what they're getting into before they start the ketogenic diet, and that's actually a choice of theirs, that they really want to do this before we even get started, because we can always go to the next medication. There's always an option for that, and we can start the diet kind of when we need to. So I had mentioned that there are 2 different diets, so I want to kind of go through what these mean. There is a classic ketogenic diet, maybe sometimes called a medical ketogenic diet, and this one is initiated in the hospital. This is one where all of the food that the patient eats is weighed on a gram scale. It is set to a certain ketogenic ratio, which I will explain. Usually on the classic ketogenic diet, we have a stronger level of ketosis, and that just means that there's a higher potential for possible side effects with the diet. The other diet is called a modified ketogenic diet, or maybe a modified Atkins diet. Sometimes we just call it MAD. We say it with smiles on our faces. But also that is an outpatient initiated diet where we are, instead of weighing food on the scale, we actually count carbohydrate grams. So, think of, just like a diabetic diet where you're measuring things out in cups and tablespoons and then deciding how much carb grams are in that amount of food. And we have a certain protocol for that and how many grams of carbs they can have in a certain day or a certain meal. And then we're adding extra fat on top of that, because remember, it doesn't matter which diet you're on, we're really trying to get our patients into ketosis, which means they have to burn fat for energy. So it is still a high fat diet, no matter which one that you use. But usually on the modified Atkins, patients tend to have a little bit less ketosis. They're not as strong as maybe our classic keto, which means that they have less potential for possible side effects. But we always say that our gold standard is the classic ketogenic diet. There's a few things that we consider in order to choose which diet we want to use for a particular patient. And a few of those things include their age. Our younger children, we might want to put on a classic ketogenic diet. Some of our teenagers and older patients, we might consider the modified version since they have a little bit more choices in their diet. Feeding ability, like if they're tube fed, then we're going to definitely go with a classic ketogenic diet because our formulas are set to a certain ketogenic ratio. A diagnosis might make a difference in which diet that we choose, and also just social considerations. So I'm thinking, if a patient goes to daycare or is watched by their grandmother, or just school-age children, some of these things might make a difference into what diet we actually choose for our patients and families. So this ketogenic ratio that I keep talking about just means that we are using grams of fat against the grams of non-fat in their diet. And that non-fat portion are grams of protein and carbohydrate kind of added together. So actually, like a common ratio might be a 4-to-1 ketogenic ratio, or even like a 3-to-1 ratio. And that just means the amount of fat to non-fat in the amount of calories that I want to give my patient. So it might be, like a 4-to-1 ratio might be 90% fat. So to kind of put that into perspective, when we think about carbohydrate grams, it might be anywhere between 2 and 10 grams of carb for the whole day. And if you think of, if you're not a carb counter or know what that might look like in terms of food, one slice of bread usually is around 15 grams of carbohydrate. So our patients that are on a higher ratio of the ketogenic diet might need less grams of carb than even like one slice of bread for their entire day. On the next slide, I'll show you that an avocado actually is the perfect keto food. It is in a 4-to-1 ratio all on its own. So that's the amount of fat to carb and protein added together, remember. A lot of foods are not in a certain ketogenic ratio. So what we have to do is kind of add these things together to create our ratio. So I would take a certain amount of butter, which would be the fat portion of their diet, and a certain amount of green beans and a certain amount of turkey, for instance, added together. And when you add all these, you assign gram amounts for each of these foods, then you know what a certain level of the ratio would be. Sorry, I had a screen problem there. Okay, next slide, please. So this would be what it looks like on a plate. This would be a little bit of chicken and green beans and pasta. You can see there in our general diet plate. There is butter on top of those just to kind of show like what you might be cooking it with or what might be mixed in there with a glass of milk. On the other side, we have a ketogenic diet 4-to-1 ratio. So you can see the amount of chicken and green beans kind of goes down. The amount of butter is definitely increased. It almost looks like more than anything on the plate. And that is not milk there in that cup. That is actually heavy whipping cream. And we would use a few ounces of that instead of our milk, which has carbohydrate in it and not enough fat. So what always blows my mind about these two pictures is that you have the same amount of calories in each of these plates. So even though the portion sizes are quite different for each one, you get more bang for your buck with the butter and the amount of fat that's on that plate. So you get a lot more calories that way in smaller little portions. So you can get the same amount of calories with less food. So it kind of tricks your eye into thinking that it is less, but it actually you're consuming the same amount of calories. Go ahead. So this is kind of how I create meal plans according to the ketogenic diet. I pick a protein and a carbohydrate to begin with. And, these are very kid-friendly foods that I put in this list. This is not an exhaustive list. This is just a common list that I use. But I would pick one of the protein foods based on what the child already likes to eat. I think that's very helpful when we have them, when they're compliant on the diet, is kind of using the foods that they already like. And then, of course, the carbohydrate portion of the diet here would be a fruit or a vegetable usually. So there's no grains associated, with this list. We want to try and get a fruit and vegetable in throughout the day, even though they are on a ketogenic diet, and that is a carbohydrate source that we want them to have. Then we would add in the cream portion of their diet. And usually that's just heavy whipping cream and they just drink it. We're in the Midwest, all our kids are drinking milk. So they're just used to doing that. And so we just replace the milk with just a small portion of heavy whipping cream, and they usually just drink it. But you can get creative and you can freeze it and make it into ice cream. I've seen a variety of different things that you can do with this. You can whip it and then, put it on some strawberries. But also the fat portion, we need more than just the heavy whipping cream. We also need something like butter or oil or mayonnaise kind of as part of what would be on their plate also. So this is what it would look like when I'm creating meal plans in the Keto Diet Calculator, which is kind of an online password protected program that I use to house all of the recipes and meal plans for all of our patients. So you can see the amount of grams for each of the food items here. So you would have heavy whipping cream and apples, and you can see tuna and a certain amount of mayonnaise. So they would take a gram scale and they would weigh out each one of these foods. And then you can kind of mix and match whatever you wanted. So of course you're going to mix the mayonnaise with the tuna and kind of make like a tuna salad, which would be easy to eat and for a younger child. And they could eat that with apples and then drink their heavy cream. And you can see that this meal plan in particular is a 3-to-1 ketogenic ratio. If you look at the yellow line that goes all the way across to the right, this is a 3-to-1 ratio at about 244 calories, which might be typical for a smaller child. And then this would just be one of their meal plans for the day. Here's just more food pictures for you, so you get the idea of what different ratios might look like. And so you have a 1-to-1 ketogenic ratio that is on the bottom right in the green there. So you can see that's probably, I think it's chicken and broccoli and maybe some mayonnaise, kind of like as a dip. And you can move all the way around to what a 2-to-1 ratio might look like using those same foods, and then a 3-to-1 and a 4-to-1 ratio. And we do use all of these ratios. It just depends on the level of ketosis that each of our patients needs in order for it to be helpful for their seizure control. Also, there's side effects and other things that we have to help control. And we can also, use this as kind of the dose of their diet. If you think of, using medications at a certain milliliters or milligrams, this is how we think of the diet. A certain ratio of the diet is kind of the dose of their diet. So some of them might need a higher ratio of the diet. Some of them might need a lower ratio, just depending on the whole big picture. But again, looking at this slide, makes me point out, you can see all of these plates are all 400 calories. So this might be for an older patient, but the 4-to-1 ratio and the 1-to-1 ratio look very different on a plate, and yet still it's 400 calories no matter how you cut it. So it does make a difference where all of those macronutrients are coming from, and the higher amount of fat that you have it doesn't mean that all of our patients are just going to get fat because they're eating tons and tons of calories coming from fat. We really are controlling the rest of the calories and how much is coming in there so that we can have the right ratio and percentages of all these macronutrients. So I'm going to take you through different life stages and how we do the ketogenic diet through each one. So we can definitely do keto for infants, and this is what it would look like. We do have a ketogenic formula that we use here at the hospital. It's called Keto-Cal. There's a keto name for everything that we have. You know, we would be able to substitute out the formula that the baby was taking, or even mix that formula with the Keto-Cal to create the right ratio of the diet that we want. As you can see, Keto-Cal comes in a 3-to-1, also a 4-to-1 ratio. If we need something other than that, we would mix them kind of together to kind of get the right ratio. But also we have infants that are still breastfeeding, and we of course want to continue doing that as long as we possibly can. So they might need a supplement of a ketogenic formula to kind of help push them into ketosis, but also fostering that, that nursing and breastfeeding for as long as we can. Some of our infants are older and will take purees. So you can see the pureed peas there at the top. What we would do to make that into a keto-friendly mixture is we would weigh on the gram scale a certain amount of baby food peas. And then we would also weigh out a certain amount of butter because of course we have to make sure we get that right ketogenic ratio. So the right amount of butter, the right amount of peas, we mix them together, and then we would feed the baby that mixture that would be in the correct keto ratio. Next, we have keto for toddlers. So this is where they're kind of using their fingers in that pincer grasp and trying to, you know, feed themselves. So of course we want that development to also happen. So we can dice everything up. We can still put it in front of them, even though everything is weighed on the gram scale. We would do all of that first, and then we can offer it to the child in that way. Some of our younger toddlers might still be on a formula, so we can still use bottles if we need to, or transition to sippy cups as we can, depending on their ability and their development. But we can still use a ketogenic formula for as long as we need to, if it's helpful as part of their diet. And also, you know, Gerber stages that increase to stage 3s, you know, that are a little bit chunkier, we can still do the same thing like we do with the baby food peas. We would take a certain amount of that baby food and mix it with butter. And then that would be the portion that they could eat along with their sippy cup of either heavy cream and some milk or the ketogenic formula. Keto for school-age children gets even more and more creative as you get older. So this might be what it looks like for one of our that goes to school. Everything has to come from home. We cannot use the school meal program because it's not going to be in the right keto ratio for them. They're also not going to get exactly what they need for their diet. So everything comes from home just to make that as easy as possible to make sure that it's in their correct ratio. But also a lot of our school age kids will just eat straight butter. I know lots and lots of them that will just do that. So, you know, we might get creative and put them in little like special molds and, you know, especially with the holidays kind of coming up, you can make them into little butter turkeys or fun things. And, you know, they think it's fun, and anything that we can shape into a fun shape is helpful. But also a lot of our kids eat a lot of hot dogs, and that's totally fine. You know, we're watching their nutrition, we're getting their labs every couple of months. And so any kind of deficiencies that kind of pop up on our radar, we start supplementing for some of those things. So even if they're eating the same things kind of over and over again, if they're, you know, going to have this hot dog and applesauce meal every single day, we'll make sure that that they're getting all of the nutrition on the backside through supplements and multivitamins and things. Since we're using this, for seizure control, we need to make, like a medication, we need to make sure that they are following their diet. And then it's our job as registered dietitians to make sure that we're meeting the rest of the nutrients in some way. We also have keto for teenagers and adults. There's a lot more choices here for some of those patients. And we also might, this might be where we use our modified version of the diet and using a couple of different apps that they can use on their phones to kind of carb count and track their fat and carbohydrate that way. Also, we have a lot of older patients that will just put their fat portion, which is usually an oil of some kind, into just a little glass and just, take a swig of that while they eat the rest of their meal. It's very easy for them to do that, and they do that very easily. And then on the next slide, we have tube feeding also. So I don't want to forget about our tube feed, our patients too. So we are able to use our ketogenic formula that way also. That would just go in their tube. We can do that for infants all the way up to adults. It doesn't matter what age, we can use these ketogenic formulas. And also, all of the food pictures that you've seen, we can actually blend those up and do blenderized feedings that way too. So we have some patients that also do that. All of our patients measure their urine ketones. So it's just a strip, and for those that have diapers, we just put cotton balls in their diaper and test it on the urine ketone strip. And of course, they should be anywhere in that higher range up there, like 40, 80, 160 is typically what our range is. And we teach them how to do this. So the process of putting one of our patients on the ketogenic diet is that they first meet with our keto team in a 1-hour outpatient appointment. Right now, we're doing all telemedicine or telehealth, whatever you say, and we meet with our families for that hour, talk to them about what the ketogenic diet is going to look like for their loved one, and then we can schedule to start the diet in the hospital if we're doing a classic ketogenic diet, and that'll be a 4-day admission to the hospital so that we can teach them everything that we know about the ketogenic diet and how they should be managing it at home. And then after that, we do a 1-month follow-up visit, again with our keto team. That's the nurse practitioner, registered dietitian, and usually our social worker is kind of our trio team. And then every 3 months after that, so we can get labs and do follow-up on, is it helpful for seizures? Do we need to change the ratio? How is their weight? Do we need to change calories? And of course, we have ongoing support and counseling with our registered dietitians. Our patients always have access to us, either through the MyChart or telephone or email, any way that you can find us. That way we can help support them through their entire journey. One thing to remember is that we don't just figure out all of their food and make sure all of that is in a keto-friendly ratio. All of their medications have to be also. So of course, medications that are in liquid form are full of sugar and carbohydrate to make sure that our patients will take them and easily. So all of those have to be converted to keto-friendly versions, which usually means in a tablet form that has to be crushed and then either put in some of their keto food or like melted in water, and then they'll just take that by syringe. But that is one thing that we have to make sure that we consider prior to the start of the diet. So when should we stop the diet? I always say, well, we can stop it if it's working, we can stop it if it's not working. So in both cases, we could stop it for various reasons and at different time frames. But if it's not working and we've given it a good trial of the diet, usually, like I said, a couple of months would be typical, then we would wean them down off of all of their ratios until they were back on their regular general diet. If it is working, then what we would do usually is wean down any medications that we can. We'll wean those down, and then keep the ketogenic diet on board for as long as we need to. And then at some point we would wean the diet also after a couple of years, unless the family was adamant to stay on the diet because they felt like they were still getting benefit from it. Then we would just continue to see them every 6 to 12 months, depending on the situation. We can stop the diet if there are any kind of barriers or limiting resources for our families. Of course, all of our families are connected with our social worker in the epilepsy center so that we can try and take care of some of these barriers. But sometimes it's just out of our control, and we can't be helpful to the point of keeping them on the diet. So even by family request, we'll be able to wean them off should we need to, or even if there's side effects that we just can't, like lower the ratio enough that we really just need to stop the diet. So on the next slide, I have, what side effects we might see with the ketogenic diet. And we go through all of these in great detail with our families because, of course, we do not want them starting a ketogenic diet on their own. We want them to be connected with a good keto team who's able to follow their loved one, because some of these things can be very, sorry, I've lost my slides again. Okay, sorry. We have to watch out for some of these side effects because some of them can be serious. Constipation is probably the most common thing that we see, and we can manage those with, hopefully some extra fluids or, just changing up their vegetables. But if that's not enough, then we can use Miralax and or Senna and get them on a good bowel regimen. Usually we see lower blood sugars for our children that are on the diet, and sometimes that just means it's a new normal. It doesn't necessarily mean that they have hypoglycemia and that we have to treat it. It's just that their blood sugars run a little bit lower because they're using ketones for energy instead of sugar and glucose. So we have, new normals on some of these labs that we're okay with and know that those are fine levels to be at. Some of our patients will become kind of lethargic when they first start the diet. Of course, if those things continue, then we're going to want to follow them a little bit closely and get some more labs done and kind of figure out why that might be. But also drug interactions. Most of our patients are still taking anti-seizure medications, and some of those things can interact with the diet also, which is just another reason why patients and their families should not be doing this on their own. We really want to help them monitor it the best that we can. Metabolic acidosis can be common, especially in combination with some other medications. So that's something that we watch for in their labs, and we'll give them a buffer or a citrate in order to help with those CO2 levels. We watch for vitamin deficiencies and, of course, their lipid levels. We can expect cholesterol and triglycerides to increase a little bit while they're first starting the diet, but that's usually a transient increase, and we can see their levels come back down to their normal baselines after a few months. So most of these side effects are acute and reversible, and we know what they are and we know what we're looking for, so we can kind of be able to be proactive in order to keep these things at bay. So just to kind of wrap up here, if you wanted to refer your patient to our keto team, what you can do is just go through our epilepsy center. Unfortunately, you won't be able to just directly give a referral to keto. We would is actually going to come through the epilepsy team. So you can send a referral form to our epilepsy center, and then what we would do is kind of review the notes from a neurology type perspective, and then get them in to see our keto team. So just go through the epilepsy center office, and of course you'll have all those numbers and that contact information. So here's how you can find me in particular, if you want to. My email is there, the Epilepsy Center phone number is there, and also you can go to our website at luriechildrens.org and just do a search for Ketogenic Diet. Thanks so much for your attention.
Thank you, Robyn. That was awesome. I think that was a great presentation. I learned a lot. I was amazed by the 86% number of, working here as long as I have, I didn't know that number, and I'm pretty amazed by it. At this time, I'd like to see if anybody has any questions. If you feel like you want to ask a question, go ahead and hit the hand button on the screen. We can go live with that or type it in. While that is going on, I am going to remind you that we have another session at 5 o'clock with Dr. Joyce Wu, section head for epilepsy, the Epilepsy Center, and she'll be talking about epilepsy surgery. Julie, do you have any questions today?
You know what, I do. I just was curious whether or not with the smaller portions, even though the fat content is higher, do you find that the patients need to eat more frequently during the day?
No, we don't. They actually stay on their schedule pretty well. You know, we aim for 3 meals a day for our oral feeders, and a couple of snacks. You know, when they would normally eat, we try and make sure that we, you know, keep the same regimen that they came to us on. We try not to change any of those things. But also being in ketosis can be an appetite suppressant. So it's just that being in ketosis, you're just not as hungry as you normally would. Your blood sugars are not going up and down and kind of causing that hunger to kind of hit you in the same way. So everything is very steady. You know, we have some kids that will be just ravenously hungry and they're growing. And so we have to make sure that they get more calories than the average child their age. But, you know, those things also fluctuate. They are moving targets all the time. So, you know, so that's why we keep in close contact with them to kind of just make sure that we're on top of those things. But yeah, not necessarily wanting more. Calories actually drives everything.
Thank you. That's all I see, Chad, for questions.
Yep. Are tree nut allergies a big hindrance when you're planning a diet like this for kids?
It definitely makes me think a little bit more. I have to do a little more homework when I have children that come to me with certain allergies, whether it be a milk allergy or a nut allergy. You know, we do have to adjust some of our fat sources because of it. You know, we might have to use ghee instead of butter, you know, if there is some kind of milk allergy, or maybe they're using more oils, but there's always an option. And I feel like even though we have these little hurdles to kind of get through, there's always a way to put them on a ketogenic diet.
Yeah, you went through, you were pretty thorough with everything, and it was pretty great. I see a note just came in from Ellen Avery. How many of your patients decide to start the diet after meeting with you versus not starting the diet? Do most start?
I think most of them start. I don't have certain percentages. I don't keep track of that one. I keep track of a lot of things, but not that one. So I would say most of them do start, because I think by the time that they are ready to have an appointment with our team, they're already, you know, looking into it. They've gone on the Charlie Foundation website. They're getting some information maybe from other families. And so they know a little something about it. And most of them are pretty ready to begin by the time that they're meeting with us and just learning a little bit more.
Okay. Well, I think that is it. There's no more questions out there. So I'm going to thank you once again for joining us today. You were great. It was a wonderful presentation. And as I mentioned earlier, this session is being recorded and we will be sending that out. So I encourage you to share it with your colleagues as well. But that's it for now, and I'll see you all at 5 p.m. with Dr. Joyce Wu. Have a great day.
Thank you.
Thank you.